Good morning. It's 7:30 and it's time to start our grand rounds. Just a quick reminder that the CME code is in the chat box and we'll keep repeating every 10 to 15 minutes. And also, if you can complete the evaluations which Delia sends after the grand rounds, that will help me provide feedback to the grand round speaker. It's my great pleasure to introduce this morning's grand round speaker, Dr. Roli Agrawal, who is a radiologist at Corewell Health System in Southeast Michigan and Windsor Regional Hospital, Windsor, Ontario. She completed her pediatric residency in one of the premier institutions in India, known as Postgraduate Institution in Chandigarh, India. Then she moved with her family to Michigan, where she did her pediatric residency at Children's Hospital in Michigan. Subsequently, she decided to change her field of specialty and did her residency in radiology at Detroit Medical Center. And she wanted to subspecialize, so she subsequently did a pediatric radiology fellowship at Children's Hospital in Michigan. And that was not enough for her, so she decided to do 1 year of neuroradiology fellowship at Corewell Health System. And subsequently, she also did her MBA. So she's very well educated and trained in pediatric radiology and neuroradiology. And today she's going to discuss with us neck masses in children, when to worry and how to investigate. Dr. Agrawal, thank you very much for accepting our invitation. We're looking forward to your presentation. The floor is yours.
Thank you, Dr. Kamath, for giving me this opportunity to present one of my favorite topics. And before I start, I would like to wish all the physicians, all residents, fellows, pediatricians, family physicians, a happy Physicians Day and Physicians Week. And thank you for what you all do. And as you can see, I couldn't do it. And so I moved from pediatrics to radiology, but I absolutely love what I do. And this is one of my favorite topics. And I will start out with a case. It's a 15-year-old girl who presented to an outpatient clinic in a pediatrician's office for swelling in the back of neck. And on history, it was present for 4 weeks, and she complained of some pain, no restriction of motion. She denied any history of fever and other URI-like symptoms or any systemic symptoms. And on physical examination, this was a firm, non-mobile mass, which was present in posterior neck and overlying skin, and the local regional examination of scalp, rest of the neck, oral cavity, back, everything was negative except for a solid, firm mass in her neck. So as part of the workup, the CBC was sent, and she was sent the same day to the pediatric radiology department in Windsor. And the first imaging modality for all pediatric neck masses is an ultrasound. That's the gold standard imaging assessment that we do. And you can see this is a grayscale image of an ultrasound of her region of concern, area of concern in her posterior neck. And we can see there is a heterogeneous hypoechoic mass, which has on this ultrasound well-defined superficial border. However, the deeper assessment is kind of limited because of these hyperechoic or bright areas that we see, which are curvilinear. And on the deep side, you can see some shadowing. We call it acoustic shadowing or dropout of the signal. That is related to calcification. On the left side of the screen, that is the calvarium. So it is between her skull, the calvarium, the head, and on the right side of the screen, these hyperechoic deeper areas are the vertebral body, the C1, C2, we are catching that. But this is an ultrasound, and therefore the assessment is limited. So on this, so we compared it to the normal contralateral left side, and there was no mass, as it was a solitary mass. And so the differentials were a soft tissue sarcoma, which could be a rhabdomyosarcoma, which could be a extra osseous sarcoma. Some of the bony tumors, they can have extra osseous component. it could be, this was a patient who had a history of travel, so there was a concern, could it be a tubercular lymphadenopathy, though the location is somewhat unusual, and this is a previously healthy child, so a treated lymphoma or a tubercular disease or sarcoidosis, like a caseating mass with non-infectious etiology, was also in the differential, but less likely. Other that we thought, which is the lesion that we thought about, could it be a desmoid, which occasionally can present as a calcified mass, but those are some of the rarer lesions in this age group. So the second investigation of choice was a CT scan, which confirmed the calcified mass in the posterior right neck. We compared it to the left side, there is nothing else. And the rest of the CT neck was also negative for any other mass or lymphadenopathy. Upon further review of the images, there was no involvement of the bones and vessels. However, there is some edema surrounding this mass. As you can see, there is some hypodensity, and the fat planes are a little bit obliterated or obscured when you compare it to the normal left side. A MRI was performed, which did not actually add much to our diagnoses or differential diagnoses. And the next choice of examination or the further assessment was a ultrasound guided biopsy, which revealed a desmoid fibromatosis. So what we glean from this case is that if a good history and physical is performed, you can actually narrow down which in this case, we thought of either a soft tissue sarcoma and or possibly a desmoid, which was discussed with the pediatrician. So what we are planning on achieving after this presentation, some differential diagnoses of common neonatal and pediatric neck masses. How do we do a history and physical, which you are well versed than I am, but then depending on the history and physical, what should be the diagnostic approach, especially imaging modalities. Most importantly, role of ultrasound, which can be performed at bedside, in the acute settings in emergency room or urgent care, and in non-urgent cases in your pediatric clinics or at the bedside on the floor. Other more important objective of this presentation is to identify some of the outliers or conditions that may mimic common benign etiologies and may have significant consequences if not diagnosed and managed in a timely fashion. So neck masses are divided into congenital and acquired. And among the congenital, most common is a cystic lesion, which is thyroglossal duct cyst, usually presenting in the midline. They usually do not present in neonatal age group, but later in childhood. Among the common acquired etiologies are infectious etiologies, which is the most common, reactive lymphadenitis or lymphadenopathy, which may go on to present as abscess formation and other complications, which we'll discuss in detail later in the presentation. Some of the other common non-inflammatory benign lesions that present in in our department, radiology department, and to you in your clinic are fibromatosis coli, some of the common small masses, which are pilomatrixomas, other vascular lesions, which are infantile hemangiomas, and some uncommon vascular lesions or malformations like lymphangiomas, congenital hemangiomas, which are rarer but can mimic an infantile hemangioma with their atypical presentation, and some benign and malignant neoplasms, which are thankfully not that common other than lymphomas in the pediatric age group. In the interest of time, I'm going to skip the embryology for now, and we'll try to get to it when we are discussing the congenital lesions. So most of the diagnoses for the pediatric and neonatal neck masses, and I will focus on neck masses today because head and maxillofacial masses or masses of the face, they deserve another separate lecture or separate grand rounds. Some of these lesions are common in scalp and face and neck, so there will be some overlap. However, mostly I would focus on neck masses today. And Then you are trying to review, try to come up with the diagnoses. A detailed history is imperative. As you all know, you want to know at what time did they present. If it was present at birth, if it was fully formed at birth, then it would be an uncommon congenital hemangioma, or it could be a small branchial cleft cyst, though they usually present later in life when they get either infected or there is some trauma and resulting in some hemorrhage within the lesion. If they are inflammatory or infectious, the most common being pediatric lymphadenopathy, is if there is a rapid growth, is there that would point towards an infectious process, but rarely aggressive type of non-Hodgkin's lymphoma can also have a rapid growth rate, and those lymph nodes may come up in a span of 1 to 2 weeks. You want to ask for associated systemic symptoms. Where are they present? In our case, index case, it was posterior neck, and it is an uncommon location for neck masses, the most common being still lymph nodes, but rarely, like in our case, could be a soft tissue sarcoma or a desmoid. Are they single or multiple? Are they just in the neck, or there is something, there are other lymph nodes or other masses that parents or child has noticed in the rest of the body? Are they noticing any changes in the skin color? Is there a bruise? Is there a purple birthmark or violaceous plaque that they have noticed? Is there any history of exposure to animals or any history of recent travels? During your physical examination, you want to look at the location. They're midline or lateral. The list is not complete because in this on this slide, but some of the midline lesions are thyroglossal duct cysts, rarely dermoid cysts, which are, or the inclusion cysts, which are more common in scalp and along the orbits on the medial or lateral aspect of the orbit. But in the neck, though they are uncommon lesions, they may present in the midline, and most common location being suprasternal notch. In the midline, other common lesion is a thyroid nodule, which may present as a thyroid nodule, or in an adolescent, it can present, if it is a papillary thyroid cancer, it can present as a metastatic lymph node. If it's a newborn, is it a congenital goiter? Is it a ectopic thymic nodule, which may either be close to midline or in the lateral neck? On the lateral, you would know they are lymphadenopathies, your fibromatosis coli, branchial cleft cysts, the infected parotid lymph nodes, or parotitis. They are lateral. Our vascular tumors like infantile hemangiomas, congenital hemangiomas, they may be midline or lateral. They are transspecial, so they can extend from neck into the axilla or chest. Similarly with cystic hygromas. You want to know on examination if they are soft, they are hard, or they are fluctuant. Are there overlying skin changes which point towards infection? If size is more than 2 centimeters, or if it is percent or there is rapid growth, then you are concerned and you want to do a further follow-up and further workup. As we already elucidated, mentioned, if it is single or there are multiple. If it is just in the neck or rest of the body, do you see any organomegaly or any other lymphadenopathy? You want to assess the skin, if it is there is any bruise or there are associated prominent vessels, and any changes of like plaque formation, any bleeding, and if it is tender or non-tender. Additional pointers on the physical examination, you want to palpate the thyroid gland. You want to look for any drainage, which may point towards a infectious etiology like tuberculosis, or is it a branchial anomaly or a branchial cyst or branchial sinus or fistula if there is associated pitting with it? Those will point towards the congenital fistula or deeper abscess. Is there any restriction of motion? That can be seen in the cases of fibromatosis coli, and rarely a bony lesion, which predominantly is arising from the vertebrae. They may cause restricted range of motion. If your lesion is midline and it is changing position, or there is movement with trunk protrusion or swallowing, and that will point towards thyroglossal duct cyst. You want to assess the oral cavity for any infections or any dental lesions. You want to look at the skin, the regional skin, the scalp, ear, nose, and throat for any skin for basically insect bites, and then for any dermatologic conditions. Rest of the body, You want to look for organomegaly, other lymphadenopathy, and other systemic examination. So we need to understand the neck spaces. So the neck, though assessment is difficult in neonates and infants, in children and in adolescents, it's easier to define the neck spaces. But for figuring out if a neck mass is central, the central neck, it is divided into central and lateral spaces. And central is usually the 1A lymph nodes, which are inferior to the mentum of the mandible in the midline. And it includes the visceral space, which contains your hyoid bone, your thyroid and cricoid cartilage, thyroid gland, and some of the and thymus, and the suprasternal notch. So they are midline, included, and the lateral neck spaces are divided into anterior and posterior triangle with the sternocleidoid muscle. And the anterior triangle, the most important and most common neck lump that we see, or neck mass, is the lymphadenopathy, which is along the angle of the mandible, and they are most commonly reactive, or reactive lymphadenitis, which can go on to become abscess. The branchial cleft cyst, the type 1s are more common along the parotid or ear, but type 2, type 3 are present in the anterior neck space. The type 4, which is close to the thyroid gland, would present in the close to the midline around the thyroid gland. The posterior triangle, which is the lateral space, anteriorly is marked by the sternocleidomastoid, and inferiorly by the clavicle, and posteriorly by the trapezius muscle, and most common lesion there are the lymph nodes. And if, however, it is close, any supraclavicular mass, they are more common to be, or more likely to be, malignant, even in pediatric age group. The neck masses, this is the list, not a complete list, but a rough idea as to if it is cystic and midline. Uncommon lesion would be a ranula, which is a mucus retention cyst of the salivary glands in the floor of the mouth. And the most common one is the thyroglossal duct cyst, as we already talked about. The lymphangioma, the vascular malformation, and vascular tumors like infantile hemangioma, they can be either lateral or midline in the neck, and can extend into the other body parts. And as we discussed, the thyroid, the fibromatosis coli, ectopic thymus, depending on the location, if ectopic thymus is within the thyroid gland, then it is more kind of midline or close to the midline. But if it is along the ectopic thymus, can also be lateral in the neck. And some of the uncommon but important solid masses, which are usually lateral, are rhabdomyosarcoma being the most common one. Less common cervical masses are teratomas and neuroblastomas. Just a pictorial presentation of the neck masses or nodules that we already discussed about. So the next step, when a patient is in your clinic or in the ER, depending on the history, if you are suspecting infectious or inflammatory etiology, if you are thinking of an infection, then your nasopharyngeal and swabs. And if you are thinking in terms of thyroid nodule or a congenital goiter, then thyroid function tests and other labs depending on your history and physical. I want to point out that most of the diagnoses, though the path to the diagnosis is somewhat, it maybe not as straightforward, but most of the diagnoses of neck masses can be narrowed down and made with a good history and physical examination. And then in non-acute settings, like when you're thinking in terms of a solid mass or a cystic lesion, when we do not have a concern for an airway compromise or acute management, then ultrasound is the first line of investigation for most of the neck masses. And we start out with grayscale images and color Doppler images. An ultrasound is very important, as we all know, because it has many advantages, like it is portable, it is non-invasive, there is no radiation. It will help us characterize the size and extent of the lesion. It will tell us if it is a solid or a cystic mass. If it is a solid mass, are there any cystic or necrotic components? What are the changes in the surrounding soft tissues? Are there any inflammatory changes? Which we will go over some of the images as to what are some of the inflammatory changes that radiologists see and comment about on their ultrasound images. On the color Doppler images, we can give you the information about the vascularity of the lesion. If there is any solid mural nodularity, then we can tell you if it is vascular or not. We can identify the vascular tumors, like most common being infantile hemangiomas. And we can also identify important, prominent surrounding vessels like arteries and veins. We can characterize mostly if it is a high flow or a slow flow lesion. However, like any other imaging modality or any diagnostic workup, it has its limitations as well. In some of the community hospitals or practices, it may not be available all the time because it is operator dependent, and you may not have an ultrasound technician on call or available 24/7 or over the weekend. But then if like some of the ERs, especially in academic facilities, an ER physician or an ER pediatrician can perform the ultrasound examination at the bedside. Other limitation is when there is calcification. When there is a deeper extent to this mass, then assessment is limited. Sometimes patient is not cooperative. Then we have to either provide sedation, or when we want to assess the deeper extent and we want to know if there is a retropharyngeal component, then ultrasound is not a good modality. Then comes the role of CT scan. In acute settings, when we are thinking of airway compromise and we want to assess the extent of the lesion, the deeper extent, and if there is history of trauma, then we are doing a contrast-enhanced CT scan to assess for the deeper extent and the infectious and inflammatory changes that are happening in the deeper soft tissues. There is concern of radiation, and parents are always asking for that. But with the newer CT scanners, with the newer generations, radiation is mostly not a concern, as those radiation doses are automodulated with the patient's age and weight. What is the role of X-rays? Whenever we are suspecting a foreign body, when we are suspecting soft tissue air, when we are suspecting a mass effect on the airway or changes in the size and caliber of the airway, when we are suspecting a retropharyngeal abscess, then X-rays come in as a quick first-line modality of investigation. MRIs. When with the ultrasound, we have figured out that this is probably a cystic lesion. However, the contents of the lesion are not very simple. And we want to make sure that this is a cystic lesion and does not have any underlying soft tissue solid component. Then we want to characterize the solid lesion, and we want to know if this is a vascular tumor or if it is a soft tissue sarcoma or a malignancy. And we want to assess the lesion, its extent, involvement of the vessels, involvement of the underlying bone, then or the full extent, because MRI has multiplanar capabilities. It has a better soft tissue resolution, contrast resolution, and it can also assess the vessels better because of the resolution. Then we are looking for, then we order MRI, and mostly with contrast, with gadolinium. What are the limitations? It is a longer exam. It needs planning. It needs sedation. It is an expensive examination, and it may not be available all the time. And there may be a long wait. especially where I practice, mostly in Windsor. Occasionally, for outpatient MRIs, there may be a wait for 2 to 4 weeks for pediatric patients, and sometimes even longer. Other feature that ultrasound is helpful is to perform ultrasound-guided biopsies or FNAs. And with ultrasound also, sorry, I'm going back to the ultrasound, we can also do some maneuvers, or which I forgot to mention, some maneuvers like if patient is cooperative and they can do some swallowing or tongue protrusion, and we can document the movement or change in the lesion size with those maneuvers. What are other imaging modalities that can be in our armamentarium to diagnose and help us assess the extent of the lesion or the mass? We talked about the X-rays. I will go over in detail how to assess the prevertebral soft tissues, but other ones are dynamic fluoroscopy that can be performed during a swallow study. We can also, if there is concern for a bronchial cleft anomaly or a cyst or not cyst, sinus or fistula, we can do a contrast injection to evaluate the patent sinus tract or fistulas. So give your radiologist a call, and we can work together to figure out what would be the best next imaging modality to assess this neck mass or neck lesion. The other ones that would be done by or recommended and ordered by a specialist would be the nuclear medicine scans. So before I go into the actual pathologies, I quickly want to go over the anatomy of the neck soft tissue lateral views, X-rays. So this is a appropriate position where the neck is slightly extended, and we look at the prevertebral soft tissues, which is usually, we compare it to the C4 or C5 vertebral body, the AP dimension of the body, and compare it to the prevertebral soft tissues. You look at the nasopharyngeal adenoids. This hypodense curvilinear area here is the nasopharyngeal airway. Anterior to it is the uvula, the soft palate that is hanging. Anterior to the uvula is the oropharyngeal cavity and the oral cavity, and then it goes into the oropharynx. There is hyoid bone. This is actually an infant, and therefore the hyoid bone here, compared to the hyoid bone in an adolescent, where it is well ossified. The hyoid bone is not ossified here, but you can see the attachment of the epiglottis on the hyoid bone, and we assess the epiglottis, the thickness of the epiglottis, and then the prevertebral soft tissues here. And anterior to the prevertebral soft tissues is the trachea. Now, unless the patient is actively swallowing and there is aerophagia, usually we do not see air in the esophagus. Mind it that in neonates and infants, the larynx is at slightly higher level, and as patients age or grow, the larynx descends in the neck and become more well-defined. So compare this lateral soft tissue X-ray to the infant's X-ray, and we see the definition of the uvula, the oropharynx, the anterior space anterior to the epiglottis, which is called vallecula, and this air-filled cavity. This is the hypopharynx, and right there are the vocal cords, below the level of which is the trachea. Right below the level of the vocal cord is the subglottic space, which we assess on AP view, and there is narrowing, then we are thinking of subglottic stenosis or croup. So whenever you are assessing X-rays in an acute setting, you want to see if there is any narrowing of the airway. Is there any compression on the airway? What are the retropharyngeal soft tissues? Is there any subcutaneous emphysema or air, which would point towards an abscess or any air fluid level? You look for any radiopaque foreign body. You look for the thickening of the soft tissues. On the AP view, again, same questions, but in a different plane. You look for the any deviation of the airway, if there is laterally displaced to the right or left, if there is any extrinsic mass effect, is there any steeple sign or narrowing of the subglottic airway? Is there any air visible in the soft tissues, indicating a pneumomediastinum, tracheal perforation, or retropharyngeal abscess? You again look for any radiopaque foreign body. What is the pitfall? Pseudo-thickening. If your patient is not the neck is not extended, or it is hyperextended, which will reduce the prevertebral soft tissue thickening. If the patient is not an extension, but it is in flexion, the baby, then it will exacerbate the prevertebral soft tissue thickening if there is swallowing or X-ray is taken in the expiration. So we always look for buckling for trachea, which would point towards the expiratory view. Repeating what I've said already, look for the expiratory phase. If you think that the baby was swallowing, or that would be actually told, usually our X-ray techs, they let us know if it was a cooperative baby or not. And then flexion of the neck usually would increase the apparent thickness of the soft tissues artifactually. In adolescents and in children, no greater than 7 millimeter. However, in younger babies, we look for C5 and compare the prevertebral soft tissues to the thickness of with the C5 depending on the age. And usually with experience, we would know what is the soft tissue thickness when we are eyeballing the prevertebral soft tissues on a lateral X-ray. Moving on to the ultrasound, in our ER, when we do it, or when you can do it in your office. What is the commonest mass? We all know is the lymph node, but we have to know what the normal lymph node looks like. They are usually oval or reniform shape. They have a thin hypoechoic cortex, well-defined smooth margins, central hyperechoic or echogenic hyla, which contain vessels, and at level 2, which is the angle of the mandible, which are the commonest site for the reactive lymphadenitis. In the short axis, in the transverse plane, up to 15 millimeter is fine, and most commonly they are reactive. This is an AP view, a transverse view of the midline neck, and we are looking at the thyroid gland, which looks like a butterfly shape, and on the sides are your cervical vessels, the carotid artery, the internal jugular vein, anteriorly the hypoechoic paired strap muscles, and on the sides anteriorly are the sternocleidomastoid muscles, and winking on the left side, posterior to the left lobe of thyroid, this is our esophagus. So this is, and look at the fat planes between the muscles and the vessels and around thyroid gland, and they are very clean and thin, clean soft tissue planes. This is our color Doppler image of a neck. And here is a normal parotid gland, homogeneous echogenicity, and with normal, non-enlarged parotid lymph nodes. Look at the superficial fat, which is very clean, and deep to it is the angle of mandible, looking as a hyperechoic line of the bone, which ultrasound cannot penetrate. This is the vein that goes through the parotid gland and divides it into superficial and deep lobes. A quick view of a normal submandibular gland, and these hyperechoic lines or striae that we see are the non-dilated normal ducts. There are no calcifications and there are no cysts or lymph nodes within the submandibular gland. So instead of going over the categories, I will go over the commonest to rarest uncommon lesions that we see in the neck, most common being the lymphadenopathy and the abnormal lymph nodes. Compared to the normal lymph nodes that I showed you earlier, these lymph nodes are more meaty, or they have more bulk to them. They still maintain the central hyperechoic hilum containing the vessels, and the fat looks more dirty. It is not as fine, thin, clean fat plane. the overlying superficial muscle, the platysma, is still maintaining its fat plane, but the lymph nodes are bulkier compared to the normal lymph node on the right side of the screen. So this lymph node is an infected lymph node. However, on the right side of the screen are normal lymph nodes. Compare the fat to the normal fat on the normal neck. This is more advanced. This baby is not responding to the antibiotics or waited too long to come present to the ER or to the pediatrician's office. The fat surrounding this lymph node appears even dirtier or even more hyperechoic with loss of surrounding planes. And this lymph node has suppuration or liquefaction setting in. More damage being done. Now it's developing into an abscess. And here we can see that there is the vascularity is not in the center. Now we do not see a central echogenic hilum. However, that is lost. The vascularity is now in the surrounding soft tissues, which tells us cellulitis and which tells us that the infection is no longer contained within the lymph node and has spread to the surrounding soft tissues. A pediatrician, a ER physician, and a radiologist nightmare, a retropharyngeal abscess. And this is a infection in the nasopharyngeal lymph node, which ultrasound cannot get to. And when we are suspecting this, because our baby is irritable, the neck is hyperextended, baby is drooling, there's salivating, there is fever, and we go to our x-rays where we compare it to the x-rays that I showed you earlier. There is retropharyngeal or prevertebral soft tissue thickening, way more.
Roli, I don't think we are seeing the slides correctly. We see slide 34 right now, 35. Is that what you are pointing at?
No, 34 is this. So this was.
This is thyroid on the slide, 35. Okay, somebody's saying they saw 38. So maybe my laptop is behind.
Okay, so right now I'm pointing to slide 34, which is a infected lymph node. And on the right side of the screen is a normal lymph node.
No, we don't. Does everybody see that? I mean, I don't see
I'm seeing slide 36. It's been all off.
Is it all off? Okay.
How about this?
This
is slide 36 on my end, and it is a infected lymph node with suppuration and abscess formation.
Oh, we see slide 37 right now.
Um, 37
with some Doppler.
Okay, so this is 37, and this is a infected lymph node. On the right side of the screen, there is hyperemia and vascularity in the surrounding soft tissues.
Okay, now we see 38 with the neck radiograph with widening of the retropharyngeal space.
Okay, so there is some lag when I'm presenting, and you will. Okay, so 38. So I guess I need to go a little slow then, probably. So now you're seeing 38 the X-ray?
Yes, X-ray, yeah.
Okay. Okay. So did everyone see slide 36, where this is an abnormal lymph node with liquefaction and suppuration forming an abscess?
So yeah.
Okay.
So this is 34. Yeah.
And now this is an X-ray, a soft tissue lateral neck, where there is prevertebral soft tissue swelling. There is mass effect on the airway, which is displaced anteriorly. This is the X-ray.
No,
does everyone see that?
No, this is ultrasound 36. And this is again ultrasound with Doppler showing hyperemia, basically.
Dr. Kamat, I can see 38.
You see 38? Maybe my laptop is behind.
I still see 37.
Same thing you are.
I'm still seeing 37. Now I'm seeing 38.
Now we see 38.
I think depending on everybody's internet speed, there is some lag.
Okay. So if you can just say what slide you are showing, I think we can.
Sure.
So this is 36 right now. This is 38.
38. I am showing 38, which is an X-ray soft tissue lateral neck.
Okay.
And now I have moved on to slide 39, which is showing, because X-rays are limited to show the extent, because retropharyngeal abscesses, they have further complication of extension into the mediastinum, causing the abscess can extend into the mediastinum because of continuation of the retropharyngeal space with the posterior mediastinal space. And this is the abscess that we saw on the lateral X-ray. Does everyone see that? And it is extending into the mediastinum, and this is on the upper right corner is the axial view of the CT scan of the mediastinum. So just the retropharyngeal abscess, the complications are, so I'm showing the slide number 40, complication of retropharyngeal abscess with anterior compression of the airway, extension into the mediastinum. It can extend into the carotid sheath and cause jugular vein occlusion or thrombosis, rarely in the carotid arteries, with extension into the carotid space. It can result into sepsis, and occasionally the atlantoaxial rotary subluxation. Now I'm showing slide number 41, which is again ultrasound, grayscale and color Doppler. And it is similar looking to what I showed earlier in acute lymphadenitis, a suppurative lymphadenitis. But if this is a long-standing process, then either it could be a partially treated lymphadenopathy, a lymphadenitis, or in case there is any exposure or any history which is concerning, it could also be tubercular lymphadenitis or tubercular infection. Tubercular infection, however, can have internal calcification. They can also extend into the surrounding soft tissues with the sinus formation. If you're performing an ultrasound or your radiologist comments that there are calcific foci within the lymph node, then there could be a possibility of a tubercular infection. It could be related to a previously treated lymphoma. And if it's an adolescent, you should also consider, if it is an abnormal looking lymph node with a recent history of neck lump, you should also consider a metastatic lymph node from papillary thyroid cancer in an adolescent. I'm showing slide 44 now. I'm just covering the lymph node at this time. And this is a lymph node which is very abnormal. It has lost its reniform shape. It is solid. It has lost its central echogenic hilum. There is no differentiation of the cortex and the hilum, and it is rounded and very meaty or bulky looking with another adjacent similar looking lymph node. There are multiple of them, and that is a lymphoma. Now, an aggressive non-Hodgkin lymphoma can present within a span of a week or two, but more commonly it involves the Waldeur's ring, which is the tonsils and adenoids. Not just lymphoma, but as I mentioned, thyroid cancer, some of the sarcomas and neuroblastomas can also metastasize into the lymph nodes. Now, this is slide 46. This is an important slide, and it is showing different kinds of abnormalities in the lymph nodes, which are the commonest lump in the neck. So this is on the upper left corner is a lymph node which has increased cortical thickness. So it is abnormal. There in the second image, there is hyperemia. So it is an infected lymph node with hypervascularity. In the third image, in the upper row, there is complete loss of echogenic hilum, and the surrounding fat looks very abnormal, and there is loss of there is increased hyperechogenicity in the surrounding fat and loss of normal fat plane. The upper right corner is a lymph node where there is loss of definition or the margins of the lymph node, which could be either because of infection or because of extranodal spread of the disease and commonly metastases. Moving on to the bottom line, this lymph node is abnormal and there is either central eccentric necrosis or cystic changes, depending on if it is cystic changes or necrotic changes, those can be seen in metastatic lymph nodes of papillary thyroid cancer. If it is infectious, then it can be because of suppuration. Another lymph node with lumpy, bumpy contour, that is also abnormal. And then I already showed you a lymphoma. So this is the third image in the bottom line, which is showing a very abnormal looking, bulky, solid lymph node, which has not the vascularity not contained in the center, not restricted to the center of the hilum, but the vascularity is in the peripheral lymph node as well. Other common lump that we see in pediatrics are the parotitis, and they are lateral in the parotid gland, which could be either, the most common being viral parotitis, and the next common is HIV or juvenile recurrent parotitis. And occasionally, a parotid infection can be an infected type 1 branchial cleft cyst. However, they are not very common. I'm showing slide 48 right now, and a normal lymph parotid gland, as I already showed you, but now I'm on slide 49 and showing an abnormal parotid gland with heterogeneous echo texture and multiple tiny hypoechoic foci, which are demonstrate on the color Doppler images increased vascularity. Other common lump that we see in our neonates and in my community practice in Windsor is fibromatosis coli. And I'm not going to go in detail because you all know what it is, but I want to show you the normal sternocleidomastoid that I showed you with the thyroid gland image, that this is a normal fusiform sternocleidomastoid, which will follow the echo texture of a normal muscle as in the rest of the body. However, on the right of the screen, there is bulky sternocleidomastoid, which when we scan it along the oblique plane of the sternocleidomastoid, we can show you that this, which is important, is that it is not a focal mass, and it is a fusiform ellipsoid enlargement of either the entire sternocleidomastoid muscle or part of the sternocleidomastoid muscle. And it moves when we try to turn the baby's head, though there is some restriction of motion sometimes in these babies, but we are able to document that with an ultrasound scan. And it follows the echogenicity of a normal sternocleidomastoid with occasionally some heterogeneous echo texture. Another example, this is ellipsoid enlargement of the sternocleidomastoid on the left side of the screen, and on the right side of the screen is a normal sternocleidomastoid, and I'm on slide 51 right now. Other common lesion, vascular tumor, is infantile hemangioma. And what I want to emphasize is that the diagnosis usually is clinical, and there is a proliferative phase. They are not present at birth, but may have a precursor skin lesion. There is a early proliferative phase within first couple months of life, followed by a stationary phase, and then there is an involution phase. So usually infantile hemangiomas do not require any imaging unless they are multiple, if it is not following a typical clinical picture, unless there are some atypical features of pain, bleeding, or patient has some other, you're concerned about a deeper extent, and then they are present in the beard distribution, or there is an airway compromise. And other times when we need imaging for infantile hemangioma is when you are thinking in terms of association with other syndromes like Facey syndrome or in lumbar sacral syndromes. Remember, when there are multiple skin lesions, which we call blueberry muffin lesions, they are not just present in cases with infantile hemangiomas. Some other more sinister etiologies can present as blueberry muffin lesions like neuroblastoma, like LCH, and occasionally infantile fibromatosis. They can also present with bluish or purplish skin lesion. So whenever, however, these patients present to us in the pediatric radiology department, we actually take a picture with the consent, and we include it in our PACS in our records, in our PACS archives, along with the ultrasound images, so that the radiologist can also follow the evolution of that lesion and compare it to the previous imaging. Because infantile hemangioma, when they present to us in proliferative phase, they are very homogeneous, and I'll show you images. So they are very homogeneous, and they will present. So this is image of infantile hemangioma. So I'm at slide 55. So infantile hemangioma in its proliferative phase is homogeneous, hypoechoic, and it is filled with low resistance vessels, which are completely filling the lesion that we see, and there are no solid soft tissue component. This is proliferative phase. However, if they present to us later and parents say that it is reducing in size, so that is involutory phase, they can have more heterogeneous echo texture, and we will have areas where there is no vascularity. Beware of the sinister etiologies or etiologies which are not infantile hemangioma but may look like infantile hemangioma. And why is it important? Because infantile hemangioma would respond to propranolol and similar class medications, and usually and other etiologies which may mimic infantile hemangioma will not respond to medical treatment, and they may require certain other treatment and may have other complications. So, and what are the other other neck masses which can mimic infantile hemangioma or congenital hemangioma? Some vascular tumors or vascular malformations like AV malformation, venous malformation, some sinister vascular tumors like Kaposi hemangioendothelioma, other tumors like rhabdomyosarcoma, and infantile myofibromas. But the history is imperative in trying to differentiate these lesions from the more common infantile hemangiomas. And on imaging, what do we see? If there is heterogeneous echo texture, if there are internal cysts, if there is necrosis, if there are abnormal large vessels, and if there is internal calcification, then usually it's not an infantile hemangioma. Then I look at the lesion and there are solid components, which in general, there is vascularity in the lesion. However, it is not as vascular as the infantile hemangioma. And that is when we are concerned that this is not a run-of-the-mill vascular tumor, which is infantile. Sorry, my battery is running low. So we have to think in terms of these lesions. If the vascular lesion that you see is fully developed at birth, and there is concern for pain or bleeding, that's when we are concerned about congenital hemangioma or any other lesion which is mimicking the infantile hemangioma. And as I mentioned, congenital hemangiomas and other lesions, they have more heterogeneous echo texture, and they are not as smooth, homogeneous, hypoechoic lesions that we see in the proliferative phase of infantile hemangioma. This is an ultrasound of a congenital hemangioma in the neck, and compared to the image that I showed you earlier, there is heterogeneous echo texture. There are internal cystic changes or venous lakes. Congenital hemangiomas and other congenital hemangiomas may also have aneurysm, venous lakes, and some occasionally thrombosed vessels, and they are more prone to pain, to bleeding, and thrombocytopenias. Though I'm not covering the orbital masses, but this rhabdomyosarcoma of the orbit deserves a mention, because orbital rhabdomyosarcoma is a lesion, is a tumor that can, and some variants that can present in infancy, early infancy, and in the orbits, and can mimic not just clinical picture, but imaging wise, they can mimic a infantile hemangioma, and it is a nightmare of a pediatric radiologist to commit to one or the other. So this is a rhabdomyosarcoma of the neck, and this is a mass. This is homogeneous in this case. A lot of times they are not homogeneous. They may have internal cystic changes, necrotic changes. They may have hemorrhage. And however, in this case, it is homogeneous, but look at the vascularity, and it is not completely filling the mass. And on MRI, actually, it is again a mass which will be T2 hyperintense and will show homogeneous enhancement, which makes it really difficult for a pediatric radiologist to comment one way or the other. And then the multidisciplinary approach of the history, the presentation, that's where we come up with the diagnoses and try to help the patient. A picture of a orbital rhabdomyosarcoma, hyperintense on T2, homogeneous enhancement, a nightmare for a pediatric radiologist. Quickly, venous malformation. In interest of time, prominent vessels, air fluid levels, and on ultrasound may occasionally show phleboliths. And
really, which slide you are on? Oh, this is 66. On 64.
I'm on slide 66. The 66? Venous malformation. Yes.
Okay. I'm saying 64 right now.
64 was orbital rhabdomyosarcoma. So I'm showing you the venous malformation.
Okay.
There is bluish discoloration. Yeah, bluish discoloration of the skin. However, when we put ultrasound, there are actually dilated vessels, which are slow flow vessels when we put color Doppler, and it may show phleboliths in the veins and fluid levels. Other common vascular malformation, which has more lymphatic differentiation, is lymphangioma or cystic hygroma. It could be microcystic or macrocystic, and on the ultrasound, we have cysts. There are no vascularity unless there is history of trauma. Then you may have complex internal contents, but they are microcystic with small vessels or macrocystic with, not vessels, cysts, microcystic or macrocystic with large cysts. And they are usually, there is no phleboliths, and usually there is no internal vascularity. Other common lesion that I see in our practice is ectopic thymus. When a baby is crying, parents notice something in the suprasternal notch or in the lower neck, and then it goes away when baby is quiet, or it can just present as a nodule in the lateral neck, or sometimes in the midline along the thymopharyngeal duct, and that is our thymus. And it usually follows the growth pattern of the native thymus. And on ultrasound, it is starry sky pattern with homogeneous hypoechoic background with hyperechoic punctate foci scattered throughout the nodule or the lump. And if you put your ultrasound probe angled towards the mediastinum, you can confirm that the nodule that you are seeing or the mass that parents are worried about is a cervical thymus or an ectopic thymus. And occasionally, you can have these ectopic thymic rests in the thyroid gland itself. Quickly, in the interest of time, this is the congenital goiter, diffuse, I'm on slide 72, diffuse enlarged goiter, and compare it to the normal thyroid gland. One nodule that I want to cover before I end the lecture is the thyroid gland nodules, thyroid nodules, and papillary thyroid cancer is an important one because nodules in the thyroid are more likely to be malignant in pediatric age group. Up to 25% of them can be malignant compared to 7 to 10% in the adults. And they may present as nodule with punctate internal calcifications, or they may first time present as a metastatic lymph node, enlarged lymph node with punctate microcalcifications. And they need further assessment by a ultrasound-guided FNA. Pediatric papillary thyroid cancer can present first time, not just as nodule, but with the metastatic lymph node, with extranodal extension, and lung metastases. So yes, they may have advanced stage at presentation, but they respond very well to the management and require prompt referral. The cystic lesion. I moved on to thyroglossal duct cyst. Just want to show you the difference between a solid nodule that we've already, multiple that we saw, versus this homogeneous hypoechoic cystic lesion. And when we look at the ultrasound rays can pass through this cystic lesion, and we call it increased through transmission, which tells us a differentiation between a solid and a cystic lesion. And thyroglossal duct cysts are the commonest congenital cystic lesion in the pediatric neck. They are usually midline. Sometimes when they are infrahyoid, they can be a little off midline, but still within 1 centimeter to 2 centimeters of the midline. They can present with infection, and at that time, the contents can be complex, or they can present with trauma. Branchial cleft cysts, they have similar appearance on the ultrasound, and you all know how they present. Type 2 are the most common ones, and they are usually present along the carotid sheath in the lateral neck. And I think I am...
Really, I think it's the time, yeah.
Yes.
So do you want to summarize it quickly?
Yes. So in summary, the take-home points are the history and physical are most important, and they make the diagnoses in most of the patients, or at least narrow down the diagnoses where you can decide what your next line of management would be. Imaging-wise, ultrasound in non-acute setting and X-ray or CT in acute setting, especially when there is concern for airway compromise or a deep infection like retropharyngeal abscess. MRI for non-urgent cases where we want to characterize the mass or the lesion and any vascularity, and if it is cystic or solid, and if it is a tumor, what is the extent. Biopsy, ultrasound-guided biopsy, and prompt referral to the specialist like ENT or to the oncologist. Please call the radiologist. If you are not sure what is the appropriate next imaging order, if you think that the report does not gel with your clinical diagnoses, please keep in mind the more sinister lesions in the neck, the wolf among the herd of the sheep, the rhabdomyosarcoma, infantile myofibroma, aggressive vascular tumors, though they are rare, but the consequences can be devastating. If your picture of the vascular lesion does not fit with infantile hemangioma with a proliferative, stationary, and involutory phase, then it is probably not an infantile hemangioma, though diagnosis can be tricky because of multiple phenotypic variations. And do not forget that developmental lesions like thyroglossal duct cyst, dermoid cyst, branchial cleft cyst may not always present just as a lump or a lesion. They may present acutely with infection or hemorrhage. And keep in mind the papillary thyroid cancer in young patients. That's all for now.
Let's see if anybody has any questions, comments for you. So do you know if pediatricians are doing bedside ultrasound in outpatient clinics or inpatient floors for helping them with diagnosis, not with neck masses, but in general? Is it a common practice in Canada or?
Actually, not. Canada, we are, ER is doing bedside for thoras and for pleural fluid and for ascites, and especially in the setting of trauma. There is a growing movement, but at this time, I am not aware of any pediatricians doing it on the floor or in the ER. That being said, ultrasound is a modality which has a lot of applications, not just in lumps and bumps or neck masses, but also in MSK settings, and which is not in this topic, but a lot more people are wanting to learn to do ultrasound, and it is a simple modality which can be learned with some some experience. You can do it you can definitely do it on bedside or in your office. But currently, I'm not aware.
Okay. Any other questions, comments? I don't see any. So thank you all for attending this morning's grand round. Thank you, Dr. Agrawal, for that wonderful presentation on neck masses. So have a wonderful weekend, and we'll see you all next Friday at 7:30 in the morning. Thank you, Dr. Agrawal, again. Yeah.
Thank you so much for the opportunity.